Yeah, so I think broadly I'm interested in waste in the healthcare sector. I think a lot of my research has focused on sort of the capital F fraud type of waste where, people are stealing money.
So somebody who isn't really studying the healthcare system very carefully or really just, thinking about government programs might just not be aware of how much, waste in general there could be in the system. So how big is this problem?
If the government really paid super close attention, they would realize that, they're not really implementing their own rules very well in these sectors. We have some sense of that.
So it sounds like there are the incentives for the private sector, so private insurance is probably different than Medicare, right?
In general, we think about regulations as things that tie your hands before anybody does anything bad, right? So you are not allowed to bill for this type of care, or you are not, or you have to jump through these hoops if you want to, get paid by the government. My name is Riley League. I'm an assistant professor of finance at the University of Illinois Urbana-Champaign, and I research health economics and industrial organization. And this is the Cause and Effect podcast.
Second episode of the podcast, the cause and effect. So the goal of the podcast is to help our listeners understand the cause of important economic problems and the effects of government policies and programs that are meant to solve those problems. So we're going to really try to make everything accessible to anybody. I thought it would be nice to just explain a little bit of what the podcast is. And today we're going to be discussing how to reduce waste and fraud in the healthcare system. So I'm very excited to interview my friend Riley, who's also my co-author in different papers. And I'm very excited to talk about this topic. Welcome, Riley.
Thanks. Very happy to be here.
Awesome. So, can you give us just a broad overview of your research agenda? So, like, what are problems that you're interested in, and how might waste and fraud be associated with that?
Yeah, so I think broadly I'm interested in waste in the healthcare sector. I think a lot of my research has focused on sort of the capital F fraud type of waste where, people are stealing money, but also just more run of the mill inefficiencies that we have in our healthcare system. So a lot of that has focused on administrative hassles that we see throughout healthcare, things like claim denials and prior authorization. But the project that we're going to talk about today is sort of marrying that with also thinking about people stealing money from the government.
So, how big of a problem is this? So, somebody who isn't really studying the healthcare system very carefully or really just thinking about government programs might just not be aware of how much waste in general there could be in the system. So how big is this problem?
Yeah, so it's very hard to come up with an actual number on the amount of fraud or amount of waste in the healthcare system. But it generally we think that it's a very big problem, right? So the U.S. healthcare sector is trillions of dollars, right? It's by so depending on how you kind of like the largest part of our economy, and so even if a very small percentage of it is waste or fraud, it's going to end up being very large dollar values, right? So um, typically Medicare, which is the publicly funded health insurance program for the aged and disabled, uh, typically they estimate that somewhere around 5 to 10% of the payments that they make are what they call improper, which means that they should not have been paid under Medicare's own rules when they go back and scrutinize the
Hmm.
bill more closely. Now,
Hmm.
whether or not that is more or less than the amount that is fraudulently taken is, unknown, right? Because it could not accord with the billing rules for innocuous reasons, right? Doctors make mistakes, people
Mhm.
submit claims incorrectly, um, or it could be an understatement because some people are really good at stealing money, and so they'll follow the rules, quote unquote, and have all the right documentation, but they still shouldn't have gotten. And that's sort of setting aside the sort of more general notions that economists might have of waste, where it's not just a question of does this follow the rules? Would a lawyer think we should have paid this? But
Mhm.
questions of sort of inefficiency in allocating resources. And so, you know, it's a big problem, but it's very, very difficult to say how big of a problem it is. Um, and in particular, that's going to depend on what exactly the problem is you have in mind. Is it people deliberately stealing from the government? Is it the government, not doing a good job of even following its own rules? Or is it, uh, we should be able to have a better system than this?
Yeah. So if somebody's a skeptic, and they really believe that the government is not wasting any money, right, and they're contributing to the public good, or something like that, um, how could we know or have some reasonable idea then about how much waste there is? So, for example, like, could this be because of audits, and then we're trying to estimate from, a lot of transactions, X% of those via an audit seem to be wasteful or fraudulent? Is that kind of the process? How does it look like?
Yeah, that's exactly right. So the number that I cited earlier, the improper payments rate, that's exactly what Medicare does. Is they receive millions of bills every year from healthcare providers that they pay for their healthcare services, and they have a system designed to process those what are called claims and pay the money out or deny them if they think that they shouldn't pay them because it doesn't accord with the billing rules. uh, but they also will go back basically annually and draw a very small sample of claims. But given that there are so many of them, a small sample can be very informative, and say, okay, let's scrutinize these more closely. Essentially, do an audit, go back and ask
Mhm.
providers for additional documentation of what
Mhm.
they were paid for, and figure out, okay, should we have paid this bill, this claim, uh, or not, based on sort of this more intense audit process. And so that's how we can get a sense of how well Medicare and other government programs are doing at least following their own rules when they go back and try and check themselves.
Yeah. So some of this waste could be unavoidable, right? So I mean, at private firms, I'm sure there's some waste associated with just doing business in general, right? But some of it is probably preventable, and that's what your research shows, which we're going to get into in a little bit. So how do you think most of it could probably be prevented, or do you think a very large chunk of this potential waste is just the nature of the industry?
Well, it's tough to say, right? Because the only way that you're going to prevent all improper payments and all fraud is to not pay anything, or at least move much farther in that direction, right? So, uh, if you want to pay a lot of people a lot of money without too much hassle, you're going to make mistakes, right? Credit card companies, they get stolen from too, right? Like everybody gets
Mhm.
stolen from. you know, in your own sort of household budget, you probably have things that you paid for that you actually didn't mean to, right? You forgot to cancel that subscription that you're not using, right? It happens. And so there are certainly ways that we can sort of discourage people from taking advantage of that system, or that we can sort of check ourselves if we're the government. But really, in any sort of large system, there's going to be some level of payments uh, that are improper. Now,
Yeah.
that said, I think that the healthcare system is sort of there's more than you might like, or you might hope for at reasonable cost. And I think, as we'll talk about today, there are some ways I think that we can sort of reduce these this amount of the waste that we have, in ways that aren't too onerous or too difficult to implement. But the healthcare system is extremely complicated, so it's even if we compare to, well, let me say it this way: the healthcare system is extremely complicated and has lots of frictions that we think might not be present in other systems, such that
Mhm.
it would be more difficult, in my opinion, to get the amount of waste or improper payments made by government programs to levels that you would see in other more, we'll say, smoothly run systems.
That sounds good. And do we know anything about where there might be more waste and where there might be less? So, I mean, like you mentioned, it's just a very complex system. Healthcare in general, there are a lot of different sectors within it. So we got nursing homes, we got urgent care centers, we got hospitals, and then there are different government programs meant to pay for those. So we got Medicaid, we got Medicare, we got private insurance. Is there a sense of where there might be more waste, or what are some of the first or the primary areas that come to mind?
Yeah, so I think again, it's important to keep in mind the distinction between waste, meaning payments that the government
Mhm.
makes for things that they, upon further inspection, realize they shouldn't have made, versus things that are not efficient from an economist perspective. Right? Even if the government says, "Oh, we really want to pay for this, this procedure that the medical community has sort of decided is actually not very valuable for people's health," but the Medicare rules say, "Well, we're going to pay for it anyway." From the perspective of the government, they want to pay for that. Every time they actually send money out for a bill for that sort of low value care, they're happy. But an economist or maybe sort of John Q. Public might think, well, we probably shouldn't be paying for that kind of thing. That's wasteful uh, in that sense. So, setting aside that notion of waste, of what do we think we're actually getting for our money, and sort of focusing on the question of, well, if the government really paid super close attention, they would realize that, uh, they're not really implementing their own rules very uh, well in these sectors. We have some sense of that. So, um, the audits that Medicare does, they sort of release the numbers separately for different, basically, industries or programs that Medicare uh, pays for, right? So the overall number in 2019 was about 7% of spending was of Medicare payments were improper. But in the same year, I want to say that DME, durable medical equipment, which is like walkers and wheelchairs, that sort of thing, they estimated that the number was somewhere in the 20 to 30% range, right?
Yeah.
So there are certain areas of healthcare where the government recognizes that they're doing a better or worse job of enforcing their own rules. Um, but even outside of, so once we get outside of Medicare, then it gets even more difficult to know how good of a job we're doing. Right? We have a very, or at least I don't have a great sense of the rate of improper payments or of fraud for care billed to private insurers, for example.
Mhm.
Now, part of that is, they don't want to publicize how much people are stealing from them,
Mhm.
uh, but also it's tough to make sense of what the right incentives are.
Right.
In some sense, they have less of an incentive to sort of crack down on uh, providers that they think might not be doing good things, because providers have a better outside option for private insurers than with Medicare, right? Basically, everybody's going to take Medicare. But also, in many cases, private insurers are sort of more the residual claimants on what they deny, meaning
Mhm.
if they say no, they get to keep the money, whereas the entities within the government system that are deciding whether or not the government is going to pay for a bill, they generally are not going to be the same people that get to keep the money, right? It just goes back
Yeah.
to the Medicare trust fund. The government, like the national debt doesn't go up by quite as much if they say no. Whereas, if I am Blue Cross Blue Shield, Blue Cross Blue Shield, get to keep the money when I say no, subject to
Yeah.
that's on both sides.
Yeah. So it sounds like there are the incentives for the private sector, so private insurance, is probably different than Medicare, right? So that's kind of what you're getting at, right? And but I want to go back to one point that you made, which is I think we should be, before going on, be very clear about what we mean by waste. So let me see if I understood this correctly. So I'm thinking of an analogy with my own budget, for example, and my expenses. So I can think of waste as, like you mentioned, a subscription that I thought I had canceled, but I actually didn't, and it's just being charging me money, or somebody, gets my credit card information. They start buying things from that, right? So that would be one way of thinking of waste. Another one could be, I'm buying a car that I probably shouldn't be buying. I really can't afford that car, but I'm, just spending a ton of money on something that, maybe was a poor decision. So your research is really focused on the first one, right? So the things that we clearly know, this could probably just be fraudulent, or it's not what you think you'd be paying for. Is that correct? Is that
Yeah,
interpretation
I
correct?
mean, I think different projects, I focus on different types of
Mhm,
waste. I think, in general, I'm more interested in the second broader type of waste, just
mhm.
because, um, at the end of the day, the government's own rules can be wrong or can be bad from
Yeah.
at least my perspective. Right? There are things that the government has decided it wants to pay for that I think really, we as the public are not getting good value for our money, and vice versa. Right?
Mhm.
Um, and so I think generally that's what I'm interested in, but it's much more difficult to come up with numbers for those sorts of things. Right? So what
Mm.
Medicare says, we pay our improper payments rate is X. They're saying it against their own rules, not against Riley's opinion of what is wasteful.
Yeah, that's a good point. All right, so we have this understanding then of the waste that at least we can measure, or you can measure, I should say. And so you talk about three potential solutions, right? Or three approaches to reducing this type of waste. So you talk about in the paper about administrative regulations, criminal enforcement, and civil lawsuits. So let's talk about each of those at a time, so we're clear on what each of those means, right? So let's start with regulations first. What does that mean? What does that look like? And if you can give any examples that can illustrate that, that would be helpful too.
Yeah, so in general, we think about regulations as things that tie your hands before anybody does anything bad, right? So you are not allowed to bill for this type of care, or you are not, or you have to jump through these hoops if you want to, get paid by the government. And so in this context, what that looks like is having to go to Medicare, the government insurer, before the care is billed for, and say, "Hey, this is what we're planning to do for the patient. Will you pay for it?" We have to fill out
Mm.
some paperwork, and basically get permission in advance, uh, so that the government can review what we are planning to do and say, "Okay, you can go ahead or not." Right? We have to get permission. Right?
Okay.
Whereas, when we think about criminal and civil enforcement, or liability, that is generally rendered after I do something potentially bad, right? So
Mhm.
if I steal from the government, afterwards they could come after me and say, "Hey, you stole from us. Here's some punishment for that."
Mhm.
Right? And so, uh, in this context, that's kind of the distinction that we're trying to think about, where the rules are the same, right? You're not allowed to do certain things, or you are allowed to bill for care or get paid. And we're thinking about whether the government is going to sort of set up a system to review those things and make determinations on what you can do before you do them, uh,
Mhm.
versus, you have to get permission to do things, versus trying to come back after the fact, and assign, punishments based on, what was actually done. What we
Yeah.
call in paper pay and chase, litigation. Right, the government
Mhm.
isn't going to check that, somebody is not stealing from them when they're paying. Right, they just sort of pay the whoever asks them for money in a reasonable enough way, and then afterwards they're going to go and try and find the people who stole from them, and punish
Yeah.
them after the fact.
Yeah. So before we talk about how effective each of those can be, um, could you talk a little bit about what are the potential costs with each of those? Because if I'm hearing it right, we have these three potential approaches to reducing waste and fraud. Why not just do all of that? Why not take every single approach that we can to reduce waste? So, and both in terms of financial costs, but also opportunity costs associated with them.
Yeah, so I think the clearest costs are those that come from regulations that, impose costs on even people who should be doing what they're doing. Right? So if I'm a legitimate healthcare provider and I want to render somebody some medical care, and every time I do that, I have to go and ask the insurer beforehand, "Hey, this is why I want to do this. This is, what I think is wrong with the patient, why I think what I'm going to do is going to help them." That's very costly, right? Healthcare providers' time is valuable, so getting them to fill out paperwork is generally not the best use of their time, right? And so when we impose these regulations that require sort of require actions before people do whatever they're trying to do, right? When they have to go ask for permission, that imposes a cost, and in particular, imposes a cost on everybody who's going to do it,
Mhm.
not just the bad actors, right? And
Mm.
so you might think that we'd be better off not having this regulation, and instead, okay, we'll pay and then we'll find out afterwards who the bad guys are. We'll punish them. Then the only people who are paying the costs are the people who are getting punished, right? The people who actually did something wrong, either via civil or criminal liability. And the people who did nothing wrong, they don't have to deal with these costs. Right?
Yeah. Could you just clarify to the audience, like, what do you mean by civil or criminal liabilities? How are those two different?
Yeah, so I'm no lawyer, but in this context, it basically means civil liability means you have to pay money if you are convicted, essentially, is found to be in the wrong. And criminal means you could go to jail,
Mhm. Got
in
it. Okay.
addition to also paying back money.
Yeah. So both forms of punishment if somebody's doing something wrong, as opposed to asking for permission. So really, it's the those two potential paths, right? So let's get into the specifics then of the paper. So you look at non-emergency ambulance rides for patients going to dialysis facilities, right? So can you talk a little bit first what dialysis is, why might somebody need it, how often might they need it, what should we know about this ambulances as well as the dialysis facilities in order to understand, the question you're examining.
Sure. So dialysis is a treatment for end stage renal disease, which is basically a fancy way of saying that your kidneys don't work anymore. So your kidneys, among other things, in addition to not being a lawyer, I'm also not a medical doctor. Well, your kidneys basically clean your blood. And so if your kidneys stop working, which happens to a lot of people, as it turns out, you have to either get a new kidney so that your blood can get clean, or have a treatment called dialysis, which basically involves getting hooked up to a machine that mechanically cleans your blood. So replaces the function of your kidneys, which aren't working so well anymore. And so this treatment called dialysis is very expensive, both in terms of financially it costs a lot of money, but also in terms of time. So generally, patients are treated 3 times a week for a few hours each session, and they have to travel to and from these dialysis clinics, of which there are thousands across the country. Right. I want to. This might not actually be true. I think there are more dialysis clinics than there are like Taco Bells in the country. So, but there are a lot of them. But you still have to travel back and forth to them 3 times a week if you're getting this treatment. So travel can be quite costly, particularly because many of the uh, patients who have end-stage renal disease who need this dialysis treatment tend to be, disproportionately from disadvantaged groups. Right? They have
Mhm.
lower incomes on average than folks who don't have ESRD. They
Mhm.
For them, travel might be particularly difficult financially as well as medically, right? They are sort of
Yeah.
by definition in poor health.
Yeah. And why might somebody who needs dialysis, why might they need an ambulance. So why can't they just drive there and we call an Uber for the person because ambulances are pretty expensive, right? So as
Yep.
as we're going to talk about, so why might they need that?
Yeah. So Medicare will. So first, I should also say that patients with end-stage renal disease, patients who need dialysis, are automatically eligible for Medicare after a waiting period, unlike any other condition. So the joke is that your kidneys are Canadian because they have universal health care, right? So normally Medicare is more or less reserved for people over the age of 65. But if you need to go on dialysis, you automatically get Medicare. And so Medicare will pay for patients on dialysis to be transported in an ambulance if that is the only medically safe way for them to travel. So um, some of these patients cannot travel in a car. Like they are bedridden and need to be on oxygen, right? They need to have medical care with them at all times in order to move, right? This person cannot take a car, whether it's an Uber or otherwise, right? So
Yeah.
Medicare is willing to pay for people to get non-emergency, right? You don't need the sirens going if you're traveling from your home to dialysis while a paramedic is caring for you, right? These non-emergency scheduled transports, Medicare will pay for that if you actually need it. Um,
Mhm.
but you can also see why this might be an alluring service for people for whom it's not really medically necessary, right? If you are having to travel back and forth to your dialysis session 3 times a week, and take the bus or find a friend to drive you, or whatever sort of pain it is to get there, right? And you could instead just take basically a free ambulance ride. Uh, you can see why people, beneficiaries might not object to this service being rendered to them.
Yeah, absolutely. So, well, I guess two things that come to mind. So the first thing is I had no idea that apparently your kidneys are on a different system, right? So why is it that dialysis is treated different than other diseases? Do you happen to know? I mean, this is outside the scope of your research, I know, but do you know what the justification is for that?
Yes. Well, so it's for historical reasons, like many things in the way that the system works the way it does. So back when dialysis sort of became, I don't want to say widespread, but accessible to some sizable number of patients in the United States. This was back in the 60s and 70s. It was even more expensive than it is today. It's still very expensive. Um, but there it was, not covered by Medicare or really very many private insurers either. And it was rationed so stringently that people became very, very upset. So
Mhm.
you some of your listeners may or may not remember people talking about death panels when the Affordable Care Act was
Mhm.
being, debated, whatever this was, like 15 years ago.
Mhm.
But they actually did have death panels for dialysis care, or God panels, right? So
Yeah.
people would apply, and a committee would decide who gets dialysis because there just wasn't enough to go around. And so you can imagine why people were very upset about this.
Yeah.
And so because there weren't that many patients for whom, you know, dialysis was a need, uh, the government decided, okay, we are not going to abide by, people being denied this care that they're entitled, or that they need to survive. So we're going to say, well, let's carve in your kidneys and say, if you need dialysis, Medicare will pay for it. Right? It's not that many people. Yes, it's very expensive for them, but in the grand scheme of the federal budget, it's not that much. Well, over the last 50 years, many, many more people now need dialysis than they did when this program was introduced. So now the dialysis program is about 1% of the entire federal budget. So not 1% of what the government spends on healthcare, but like 1% of all the money that the government spends goes
Yeah.
to dialysis. So
Wow.
it's still very expensive, but now it's much more common. And so
Wow.
that's where Medicare is spending their money.
Wow, that's fascinating. So I'm guessing that most of by far the biggest player in the dialysis market is Medicare. Does Medicaid and private insurance play much of a role, or is it mostly just Medicare?
Yeah, so the vast majority of patients are insured by Medicare, right? Because you've
Mhm.
become automatically eligible after a waiting period. So if you start out on private insurance, you can keep your private insurance for up to 30 months from when you start dialysis. In practice, people will switch to Medicare usually sooner than that, not
Mm.
always. And so, in terms of number of sessions, Medicare is by far the biggest player.
The biggest.
Now, many patients on Medicare, both patients who are getting dialysis and Medicare writ large, will be duly insured. So they'll have Medicare and something else. Most commonly, this will be Medicaid. So many low income patients will also be insured by Medicaid,
Yeah.
who essentially, in this context, like picks up the bill for the copay. So yeah, you in it's sort of complicated, but basically Medicare is going to pay for almost for they try to pay for 80% of the cost of the care. And if you don't have any other insurance, the patient is supposed to pay for 20% of it. The idea being that this would discourage people from getting care that they don't need.
Yeah.
In practice, it's much more complicated, right? Because if you have some other insurer, they'll usually pick up that 20%. If you're sort of in need, that 20% can get waived sometimes. If the provider treating you is fraudulent and not actually interested in following the rules, they'll just not collect that money from anybody because they're getting plenty of money from Medicare and they'd rather you go along with this than make you pay. Um, so, yes, Medicare is certainly the biggest player here
Yeah.
in terms of number of beneficiaries and in terms of their rules really dictating a lot of the way that the care is
Yeah.
rendered and paid for in this industry.
So do most patients get ambulance rides, or is it a small share? Yeah.
No, it's a small
Yeah.
share. I could look it up in the paper. I don't actually remember off the top of my head. I want to say, actually, I should look it up. This is. I can do the math. Oh no, this is the version that doesn't have the tables like fitting nice and pretty in the.
That's okay if you don't have it in front of you, but
Yeah, no, it's uncommon. Um, yeah, it's pretty
yes,
uncommon. I want to say that
it's uncommon.
something less than 5% of patients like ever have an ambulance ride.
Gotcha.
And
But
it's meant
still,
to be
even
less common than that, right? It's meant to be very few patients.
yeah.
Because again, it's
So
not you couldn't get to dialysis if you didn't get the ambulance ride because it's hard for you to travel and you don't have the money for a cab or whatever. It's you cannot travel by car. Like the only
yeah,
safe way for you to travel is by ambulance. So it's meant to be
yeah,
very very few patients again.
yeah. But so, do you know how much Medicare spends on these rides? So, are we talking about millions, billions?
Yeah, so the period that we look at is 2003 through 2017, and there,
Mhm.
Medicare spends billions of dollars on these rides. I want to
Yeah.
say about was it $3 billion? This is where not having Mia was talking. Wow. Okay, here we go. $7 billion.
$7 million. Yeah.
Okay, yeah.
Okay.
So
So it's
between
substantial.
2003 and 2017, Medicare spent almost $8 billion on almost 40 million rides, um, which I think that's a lot of money. Um,
I think most people would say that's a lot of money. So I agree with that. So what does waste and fraud look like in this specific context? So related to the ambulance rides to dialysis clinics.
yeah, so we know that in this setting, there has been a lot of what you might think of as capital F fraud. So, like people
Mhm.
who mean to be stealing money, stealing money. Um, and this is because in this setting, there have been scores of criminal and civil lawsuits in which actors have been found to have been committing this sort of behavior, right? So you should think about a company that you know sets themselves up and says, "Well, we're going to give ambulance rides." Right? I'm putting this in air quotes. Right? Where they say, "Okay, we're gonna just transport patients that we know don't really need any ambulance rides. We're not going to try and collect any money from those patients, and we're just going to bill Medicare." Right? So you might go to a nursing home and say, "Hey, who wants who," or like go to a dialysis clinic and stand outside and say, "Hey, would you like a free ride home in my ambulance?" And most people, well, maybe not most people, many people will say, "Sure, I'd love a free ride." And then Medicare gets a bill for a few $100s for that. Right? And so there's, you know, that's sort of what this looks like. You should think of this as
Mhm.
patients for whom it's medically unnecessary to receive an ambulance ride, getting an ambulance ride.
Got it. So it's really on the companies in charge of the ambulances, not necessarily the clinics.
That's right. That's right. So there are separate companies that provide ambulance services from those that do the actual dialysis care. Now, there have
Mhm.
been also sorts of allegations against the companies that do the dialysis care that they also do some shady stuff.
Mhm.
But for this for this setting, we're only thinking about the ambulance rides, which are generally provided by other companies, right? So these are companies that essentially all they do is provide ambulance rides. They're ambulance companies, quote unquote ambulance companies. And so we're not going to be thinking about sort of the incentives of the dialysis providers to try and tamp down on this behavior. We're going to be thinking about the incentives of people who might like to be criminals to set up ambulance companies and steal money. And when I say like people who want to be criminals, like there have been allegations of ties to organized crime for these companies, right? If you read these press releases, it's like, hey, this guy just decided to be an ambulance company, started an ambulance company. I mean, it really is, capital F. We're going to steal from the government. We're going to steal as much money as we can, and we're not really going to care if you if you need the care or not. Now that there's
Yeah.
spectrum. There's of course other cases where companies are perhaps less deliberate in stealing, but a lot of this is what you really what you think of when you think of stealing from the government.
Yeah. Okay. So certainly we would not like to have a lot of those. I think most people would agree. And so what is the primary research question that you have, and how do you measure that outcome? Because waste and fraud and capital F fraud, like it seems like there could be different ways of actually measuring that. So how would you describe that research question?
Yeah, so the key research question we're asking is which of these approaches that you mentioned earlier, regulation, civil litigation, or criminal litigation, is most effective at reducing healthcare fraud. And here we're going to be thinking about uh, reducing healthcare fraud as essentially being measured by how much we're spending and how many patients are getting dialysis, right? So if we see, for example, that everyone, once we sort of do something that reduces the amount of spending, one of these anti fraud actions reduces the amount of spending, but we see that patients are still able to get to their dialysis sessions, that nobody's dying, nobody's going to the hospital, right? Everybody's getting where they need to
Mhm.
go. That tells us, sort of per se, this was not in line with Medicare's billing rules, right? Medicare says
Yeah.
this is only allowed if this is the only way for you to get where you need to go. And if we can see that you still get where you need to go, but you don't need to take the ride to do it, then
Yeah.
that is, by Medicare's own rules, not something they should have been paying for.
Got it. So the idea is, if people are still getting their same services, however much we saved, that's the reduction in the waste. Is that a reasonable
Essentially.
interpretation of it?
Right. So
Yeah.
yes. Yeah. If we think that we any ambulance rides we pay for that are getting people places they were already gonna go is waste, right? I think that's a pretty good, like, that's a wasteful ambulance. Yeah, we shouldn't have been spending the money on the ambulance if they could have gotten there anyway, right? That's sort of the waste that we're gonna measure. Now, again, I want to emphasize that this is not the same as, not necessarily the same as like what an economist might like, because many of these patients, we might think it is good to sort of subsidize their travel, right? The cost for the government to do this might be less than, I have to arrange for my own travel because I am cognitively impaired and don't have somebody who can give me a ride, and I'm extremely for something like that. Here we're just thinking if you could get there without an ambulance by the government's rules, the government shouldn't be paying for that.
Got it. Okay. So how are you able to explore or examine that question? So without getting to the technical details of the econometrics here, what's your approach to answering that question?
Yeah, so the idea is that each of these anti fraud enforcement strategies was rolled out across the country at different times. And so we're able to compare what happens in places that are subject to each type of enforcement relative to places that aren't. Right. So, for example, the regulation that we study, which is called prior authorization, was first implemented in South Carolina, New Jersey, and Pennsylvania at the end of 2014. While it wasn't implemented in much of the country until after we wrote the paper, it actually is national now. But it wasn't implemented in much of the rest of the country until much later. And so we're able to see what happens in those three states that were subject to the regulation very early, compared to places that the regulation wasn't in place, to see if okay, is there a large reduction in the amount of spending in those states? Are the people who are getting rides there looking different than the people in other parts of the country? And in that way, sort of understand what would have happened to uh, patients that lived in these states that were subject to the regulation by looking at the patients in states that weren't subject to the regulation.
Yeah. So it sounds like basically the idea is we have states that are being affected by these regulations, and we'd like to have some idea of what would have happened if they weren't affected. And then the difference is the effect of this policy. Does that sound correct?
Yeah, that's exactly right. That's exactly right. And this what's really nice about these policies is that the regulation was rolled out at the state level, and the anti-fraud, sort of criminal and civil enforcement, that is handled at the Department of Justice district level. So each of these cases is assigned to a Department of Justice district, a court district, right? Which are smaller than states. So some states have one, some states have more than one. Um, and what's nice is that these cases were sort of implemented in they were tried in one place. And so we can see, okay, if there was a case in Eastern Pennsylvania, does that, uh, do things change in Eastern Pennsylvania relative to the rest of the country where this case wasn't? Uh, and so understand the effects of these criminal and civil enforcement actions.
Enforcement. Okay. So what do you find? What are the effects of this actions?
Yeah, so we find that civil litigation has basically no effect at all on healthcare fraud, while criminal litigation is much more effective. We find it over the 2 years following an indictment that about 20% spending is reduced by about 20%, which is a very large, meaningful effect. But it pales in comparison to the effect of the regulation. So we find that following civil litigation that there's basically no change at all in the amount of healthcare fraud. While for criminal litigation, we find that in the 2 years following an indictment, that spending falls by about 20%, which is not too bad, right? That's a nice reduction. But it pales in comparison to the reduction that we see from the regulation. So we find that in the month following the implementation of this regulation, that spending was reduced by about two-thirds, right? So very, very large and immediate reductions in spending on these ambulance rides. And what's really nice is that, like I mentioned earlier, we can see whether or not these patients continue to go get dialysis. And so we know whether or not it's a reduction in fraud or whether it's a reduction in care that people actually needed, right? If we impose these regulations, or we start cracking skulls and scare off even legitimate providers, then we might worry that patients who really do need these ambulance rides won't be able to get them. But that's not what we see at all. We in fact see that following any of these enforcement actions, that there is no reduction at all in patients' ability to get to their dialysis sessions, which we interpret to mean, in line with Medicare's billing rules, that this reduction came entirely from payments that Medicare should not have been making.
Yeah. So were you surprised at all by those results? And why do you think regulations seem to be so much more effective at? Because I mean, from as somebody who's not nearly as familiar with the context, right? I mean, the if people are going to jail and there are news about this, right? The criminal punishment seems like it could be pretty effective. So why do you think regulations are so much more effective?
Yeah, I mean, I think I was very surprised about this. I think in two respects. So I was both surprised at the magnitude of the effectiveness of the regulation relative to you know, the other anti-fraud measures, but I was also surprised at the lack of costs imposed by the regulation. Right, so sort of on both sides of the cost benefit, scales, I was surprised. Um,
Yeah.
Now, I think that one thing to keep in mind about the sort of effectiveness, so there are a few reasons that I think that regulation was particularly effective in this context. So one is limited liability, which is a fancy way of saying that if you get caught doing bad things, you don't always you are not always able to be punished as much as possible. Right. So if I steal a little bit of money from the government, maybe I do it on accident, right? The government isn't going to boil me in oil and like convince, make me suffer for all of eternity because I did something wrong, right? And so there's some limit on the amount of penalty that they can impose on me. And in
Mhm.
particular, when we think about civil enforcement and why it was ineffective in this context, if I've stolen a bunch of money and spent it all, I can't be asked to pay back all of that money. Or I can be asked to, but I'm just not going to do it. Right? If I got to live on my yacht and spend all this money, and then the government comes calling and says, hey, we want our money back, I can just go,
Yeah.
sorry, I spent it. Right? And so what you
Yeah.
see is these judgments for millions of dollars in damages that people should be, have been ordered to pay back that they've stolen, paid back in, you know, hundreds of dollars of increments or monthly increments, and you're just never going to get there, right?
Yeah.
And so it's very difficult to deter fraud when you can't actually punish it as much as you might like, right? uh,
Yeah.
and so that goes along with sort of the other reason that that it seems like uh, this sort of after the fact pay and chase type enforcement didn't work, which is low probability of detection, which is a
Mm.
fancy way of saying it's very hard to find the needle in the haystack of bad actors, right?
Mm.
This is a setting where there are thousands of firms that are all providing services to the government. And it's very difficult for the government after the fact to go and check, okay, this one uh was this one firm one that was doing something wrong or not,
Yeah.
right? And so, while we see thousands of these firms rendering care and many of them exiting as soon as they're required to ask for permission in advance, uh, we only see, a few dozen of them face criminal or civil investigations or sanctions, right? And so
Yeah.
this is a setting where sort of both things that make uh, after the fact enforcement scary to a bad person, the fact that they're very likely to get caught, and if they do get caught, they're going to get a big punishment, right? Neither of those are true in this setting, right? We face severe constraints on both of those in this setting, which makes sort of this pay and chase type enforcement much more difficult to actually deter people, right? They think, well,
Yeah.
I'm almost definitely not going to get caught, and even if I do, the punishment isn't going to be all that bad. Well, then maybe stealing from the government doesn't look like such a bad proposition. And what's
And the
in this setting, regulation can sort of combat both of those issues. right? So it's much easier for the government to check in advance, right? If something is correct or not, right? It's in some sense 100% probability of detection. It's not quite that, but it's much easier to detect when you have these sort of specialized people whose their entire job is to review all these claims and see, okay, is this something that we want the government to pay for? It's much easier for them to determine whether or not something should be paid for than if we go to the court system after the fact. But you need a much higher standard of proof to send somebody to jail than to go, I don't think this is what we should pay. We should pay for this. Right.
Yeah.
So what you see is, during these criminal trials, you have video, you have to present evidence where it's, here's a video of a patient that was supposedly bedridden, walking to the ambulance, getting an envelope full of cash, and like going about their merry day. Whereas that sort of thing, which you might need to convince a judge or a jury that something shouldn't be paid for, if you are a specialized administrator in working, in Medicare, who gets a
Yeah.
claim that goes, well, this doesn't meet our billing rules. That's much easier to adjudicate.
Yeah. And do you think that's true about like a lot of other sectors in healthcare, or do you think this is just specific to ambulances going to dialysis centers?
Yeah, so I think that dynamic is still true in other settings, right? So
Is it?
it's generally going to be the case that people who specialize in sort of reviewing claims are going to have a better sense of what's necessary and what's not than the court system is after, right? Now, that said, whether or not the two problems that I pointed out, this limited liability and this low probability of detection, whether or not those can offset the potential costs that we talked about earlier of these regulations, namely that everybody who even is supposed to be doing this has to go through the hassle of dealing with the regulation, whether or not the trade off comes off in favor of the regulation or not, that is an entirely separate question. So I think that there
Yeah.
are other healthcare contexts where this would be the case, but many others where it wouldn't. So, for example,
Yeah.
we think about there's work on hospitals doing things that the government stealing from the government, right? And there it seems like this sort of pay and chase type system is better suited for actually deterring this behavior. And part of the reason is because if you're, an academic medical center and you get a judge and then the government comes along and says, "Hey, you stole a few $1 million from us, you need to pay it back." You're not going to close, right? You have the money. And so they don't face that same limited liability constraint that these small
Mm,
fly by night firms that render this type of care, the ambulance type care in many settings, the government faces that constraint, right? They can only get back so much money from these companies, and so in that setting, there's limited liability.
hmm.
In other healthcare settings, that may not be the case.
Interesting. So it seems like the extent of liability, so very large firms versus very small ones, that might play a big role then in rather regulations would be more effective or just criminal and civil liability. Is that a good way of thinking about this?
Yeah, that's true. And I think also sort of, to think about the other side of the coin, right? The probability of detection, right? If there are a lot of really small firms that are run by, people that the government doesn't have a ton of information on, it might be harder to detect fraud, right?
Mhm.
Whereas in other healthcare settings, maybe it's not as hard to sort of do the monitoring after.
Yeah. Nice. That's very interesting. I never thought about it that way. So you also look at health outcomes, right? So one potential concern with the regulations is, maybe I actually need the ambulance, but because of the paperwork might take too long, or for whatever reason Medicare doesn't want to approve it, we might get people who are not getting the type of care that they need, right? So what do you find on that, and what was your motivation to exploring health outcomes?
Yeah, so I think you nailed the motivation for why we wanted to explore this, right?
Yeah.
You know, if you had asked me before I started this project, before I looked at the results, okay, you're going to reduce the number of ambulance rides by 2/3. Is this going to be bad for patients' health? I would say there's got to be somebody who loses here, right? Surely we're throwing some babies out with that much bathwater,
Yeah.
right? But indeed, that's not what we find at all, right? So we find that patients are just as able to get to their dialysis sessions. So not only were they sort of medically suitable to get to these sessions without taking an ambulance, in practice, they can get there without uh, taking an ambulance. Uh, and so, unsurprisingly, perhaps, we see that since they're able to get to their sessions, we don't see any changes in downstream health outcomes, right? If you don't go to your dialysis session and you need dialysis, that's very bad for your health. You will
Mhm.
very quickly end up in the hospital. And we don't see any increases in hospitalizations, particularly those that would happen if you didn't get dialysis that you needed. And we don't see
Uh,
changes in mortality.
hmm. And what do you say about what do we know about the costs associated with the regulation? So, meaning we save a lot of money, for example, on fraud, and we all those savings. That's great, but there is also a cost associated with doing the paperwork and following all the regulations. And we could think of a world where that cost outweighs, the savings that we have in Medicare spending. So, is that the case at all? Are you able to compare those costs?
Yeah, absolutely. So that's the one type of cost that we're really able to look at and rule out is these health costs, right? So, are patients not getting care that they would otherwise get? And did they need it, right?
Mhm.
And so, that's a type of cost that you see a lot of times in sort of when you impose a regulation in the healthcare sector, right? You worry that you're going to deny care for patients who need it. And here we're on very strong ground to say that's not happening, at least not in any sort of sense that we're able to detect. We're able to rule out very small effects on health, and so that we're very confidently able to rule out. The other type of costs are the costs of the paperwork, which you mentioned, which there we have to do a little bit more back of the envelope type of exercise where we say, okay, about how much do we think it costs for somebody to fill out this paperwork? How much does the government say they're spending in terms of reviewing all of this paperwork? Uh, but even there, using any sort of reasonable or really even unreasonable estimates of the cost of doing this paperwork, it comes out that the government saves so much money that that's just peanuts compared to the amount of
Hmm.
money. Now, part of the reason that's the case in this setting, I think, is that so much of the care was deterred by the regulation, right? So the amount of savings is very, very large, and there just aren't that many cases where people should be getting these rides. And so there aren't that many people who you're imposing this cost on to fill out this paperwork uh, sort of unjustifiably, right?
Hmm.
So there aren't that many people left after you sort of get rid of all the waste that
Yeah.
are unfortunately having to fill out this paperwork that they wouldn't otherwise have. Uh, Whereas in other settings, that may not be true, right? So if all we do is make everybody fill out paperwork for care they were going to get anyway, right?
Mhm.
Then you're imposing huge paperwork costs and not really getting much. But in this context, that's not a worry. The paperwork costs by any estimate that we could come up with, well, any estimate tied to reality that we could come up with was much smaller than the savings to the government.
Yeah. So it sounds like in the case of ambulance rides to dialysis center, the the benefits far outweigh any potential costs, right? So meaning the case seems to be overwhelming that those regulations are actually better than the alternative. What do you think about other contexts? So what are some implications from your research that we think we can extend to hospitals or nursing homes or urgent care centers or other types of services that are also affected by Medicare and might face similar types of concerns with waste and fraud?
Yeah, so I think that sort of the big lesson to take away here is that in settings where you think that the bad actors face limited liability, that you really can't go back and get the money after they steal it, and settings where you think it's very difficult after the fact to catch them, right? We have low probability of detection. In those settings, you really should be thinking about, okay, we might want to check before we pay out the money because the pay and chase system that is sort of the default across our healthcare system that is less likely to work super well.
Hey.
And so I think that sort of here's where I sort of start, uh, you know, going off on things that aren't really, aren't I haven't researched, but just as sort of my thoughts is a lot of this is going to be uh, in settings where, at least in the healthcare system, where you have sort of uh, smaller actors that are providing care to many people, uh, and generally you're not going to have super institutional providers, right? So one setting where you might think of as durable medical equipment, where we also know there's been lots of fraud, where there's thousands of durable medical equipment suppliers, um, and less so things like large hospitals, right? Where
Mhm.
we think that for many types of care, it's sort of easy to detect what when they do things wrong, and where if you catch them, it's much easier to get them to pay back the money.
Oh, and it's very interesting, and a lot of this insights I didn't even get the first time I was reading the paper, but about how there was
I'm sorry that the paper was so poorly written.
no, it was very well written. But I think the policy implication is just really interesting how nuanced that is, right? Because I think when I was first thinking through this was, well, it seems like criminal punishment just might never work because the probability of getting caught is so low. And that might be true in all contexts, like you said, but I think the idea of how liability differs based on the size of the provider, right? Is really interesting because even if you have a relatively low probability, right, of getting caught, but there's the punishment is so high, then people might just not do it still, right? But certainly contexts where the probability is low and the punishment is not that high, then I would definitely you would expect more people to engage in that type of behavior. So it's a really nuanced, I think, implication that is really cool. So awesome. So I guess what other projects or areas associated, perhaps with waste and fraud, are you interested in, or you have other, research on that you think connects with us? Like, is there anything that comes to mind that you might want to share? Because the listener might be thinking, okay, I learned a lot about ambulances and the dialysis industry, but yeah, are there other services and that you're interested in, and perhaps things you think this might apply to?
Yeah, so I mean, I think that the most closely related project that I'm still working on, so like this is still in progress, is thinking about durable medical equipment, where, like I mentioned, there is known to be lots of fraud, and we think that a lot of and part of that is because a lot of the problems that we sort of highlight in the ambulance sector are also present, right? Limited liability, low probability detection. But in that sort of project, we're asking, okay, another solution that you might think about rather than the ones that we think about in this paper is, what if we just changed the price, right? Increased competition so that the rents weren't so large. That is, there wasn't so much money to steal, right?
Mm.
So bank robber robs banks because that's where the money is. And so if we increase competition, that might be an even better way to reduce fraud, right? Because in general, we economists tend to like competition in most settings, right? That will drive down the price of these things rather than having, you know, these prices that are way too high for the services that are being rendered. And so you might be able to get rid of fraud that way. And what we're seeing so far is that that doesn't seem to be the case at all. That as you increase competition, that actually leads to increased fraud in durable medical equipment, in part because the fraudulent firms are the ones that are able to survive under sort of heightened competition, right? So
Mm.
if you're doing the right thing and trying to give people who really need it medical care at a very high quality, well, once competition starts driving down the price that I'm able to get, I might not be able to survive in that environment.
Mm.
Whereas it's really cheap to bill for care that you don't render, or to give
Yeah.
crummy equipment to people who don't actually need it. You don't actually have to find people who really need care. there, it's pretty easy to survive even if the price goes down really, really low. And
Yeah.
so that's one project that again is still sort of uh, we're still working on it, but I think will sort of add some more color to these questions of how we can fight healthcare fraud.
That sounds like a great topic for the next time I'll bring you in. And so let me know as soon as it's ready, and I'd love to talk about that too. But I guess one broader, lesson or something we can take from this is that combating fraud is not easy, right? But it's also we should be thinking about the incentives of the people who are committing fraud, and there's a lot of economics in this, right? If the probability of doing being caught is really low and the punishment is low, but the reward is pretty high, that works for my children. It works for grown adults. It works for anybody, right? So certainly the context of healthcare that also works, right? So people are going to be responding to their incentives, and it sounds like the we're really going into a narrow industry and a service being provided, but there's a lot of just human behavior there and how people respond to incentives. So that's why I think economics is so interesting, is that we can see this incentives playing a role in all kinds of contexts, right? But yeah, what do you think about that?
I completely agree. I mean, like I said earlier, $8 billion on ambulance rides is a lot of money to you and me. It's not that much money to the government at the at the end of the day, but I think that it is a really great context in which we can learn about these more general questions of why do we think that anti-fraud efforts might fail or might succeed? In what
Yeah,
context do we think different efforts might be more or less successful? I think that
yeah,
that's what's really exciting to me about this project is that we're able to look at this sort of little microcosm of healthcare fraud in America and hopefully learn some lessons that we're able to take to more contexts.
yeah. So I think listeners and myself, we're learning about the healthcare industry and fraud, but we're also just learning about human behavior and incentives. So that's great. Riley, thank you so much for. I've learned so much here, and I'm sure listeners will learn a lot as well. So thank you so much for taking the time to do the interview and share all the great insight that you just did. Thank you.
It was a real pleasure. I really enjoyed it. Thank you.
Before you leave, there are two things I want to tell you though. So the first one is, if you're new to the show, please subscribe and like. I really appreciate your support. It would mean the world if you can subscribe and share with people in your network, okay? So please like and subscribe. I really appreciate it. And then the second thing is, the podcast is only made possible by the generous support of the Knee Regulatory Research Center at West Virginia University. So they do a lot of research on different topics, different policies, and they're interested in understanding the cause and effect of government policies and programs, and understanding important economic problems. So if you're interested in those topics, check out their website. It's going to be linked to the description. And thank you so much for your support.